Hi everyone, welcome. In this video, we'll discuss about one of the most important neurosurgical condition, that is raised intracranial pressure. So why does this raised intracranial pressure matters for us? Imagine the skull is rigid fixed cavity. It is a bony structure. It cannot expand. So even a small volume increase in the content of the skull will lead to very big rise in the intracranial pressure. What does it do? It will lead to herniation and death if not treated immediately. So what is Monro-Kellie doctrine? Doctrine means hypothesis. It is hypothesis which states that skull is a rigid cavity. It cannot expand. It contains three constituents. First one is the brain, blood, and CSF. These three components, they occupy the skull. The total volume remains constant because skull cannot expand. So in this diagram, we have seen the three components of the skull. One is brain, blood, and CSF. These are not separated like this in the normal patients, but here for the sake of simplicity, I have separated into three components, separate components, this one. So when one compartment increases because of the maybe various pathology, in order to maintain the normal intracranial pressure, it has to displace some other component. Otherwise, the intracranial pressure increases. So, in order to maintain normal intracranial pressure, if the one component increases, it has to displace other component to maintain the normal intracranial pressure. So, if there is increase in intracranial pressure, the brain compensates. How does? The first thing is it displaces the CSF from the cranial cavity into maybe spinal cord cavity. The first displacement, if there is still increase in the intracranial pressure in the form of any accumulation of the bleed, there will be compensation in the form of venous blood reduction. The venous blood will be maybe thrown out or flown out from the cranial cavity, but compensation has limited capacity. It cannot go on expanding like maybe maintaining capacity. It has limited capacity. After that, the ICP will raise dangerously. So when you come to normal ICP values, the intracranial pressure is 5 to 15 mmHg. So when it is more than 20, it is dangerous sign. So how is ICP calculated? ICP is MAP minus CPP. MAP means mean arterial pressure. CPP, cerebral perfusion pressure. The main target is cerebral perfusion pressure. So why is it important? The cerebral perfusion pressure indicates the degree of the perfusion of the brain. If the CPP reduces, the brain suffers hypoxia. So we need to target cerebral perfusion pressure of 60 to 70 mmHg. For that, we need to control and maintain the intracranial pressure normal range. So what causes this raised intracranial pressure? So different causes ranging from trauma, EDH, SDH, tumors like meningiomas, gliomas like hydrocephalus, both obstructive, non-obstructive, edema, maybe diffuse cerebral edema from the traumatic brain injuries, infections like meningitis, they can cause the multiple causes but same pathway. These causes, they raise intracranial pressure. So how do they present? They present with headache, which is early morning headache, and vomiting, which is projectile vomiting, and they have other symptoms like blurring of vision, altered mental status. So the late features, they present with altered sensorium, papilla edema. When you see the fundus, will have papilla edema, and different postures will be there like decerebrate, decorticate, depending upon the position of the bleed, something degree of the increase in the intracranial pressure. So the red flag or most dangerous sign is Cushing triad. It consists of hypotension, bradycardia, irregular respiration, chain stroke breathing. So why does hypertension develops? Hypertension, in order to maintain the cerebral perfusion pressure, to counteract the increased intracranial pressure, the body elevates blood pressure. So that is hypertension and bradycardia, irregular respiration. This is life-threatening condition. It has to be treated aggressively. Otherwise, we may lose the patient also. How do you diagnose this one? In case of emergency, acute settings like trauma, CT scan is the investigation of choice. Why do you prefer a CT scan? CT scan takes maybe less than 1 minute to take. Other is it can show the blood very well. When in case of MRI, blood has different types of maybe difficult diagnose sometimes, but CT scan, it is hyperdense, easy to diagnose, and we can see the skull fractures in case of trauma also. So traumatic head injuries, CT scan is the best. MRI is useful some cases like tumors, meningitis, MRI is better for them. So in some ICUs, they measure the monitor the intracranial pressure with invasive maybe devices. So how do they appear on the CT scan? So because of increased intracranial pressure due to various pathologies, it will have midline shift. Here you can see midline shift. What is midline in case of CT scan? So midline is represented by this septum pellucidum, which separates the two frontal horns of the lateral ventricle, and this one, falx cerebri. So midline is represented by the septum pellucidum and falx cerebri. In case of the raised intracranial pressure, the midline here it is shifted. Normally it is supposed to be in this plane. It is shifted to left side because of the right side EDH. And sulci will be effaced here, and ventricles are compressed. You can see the ventricles are compressed this side. So this is how we can find the increased intracranial pressure. These are signs are there. So how do we manage them? Medical and surgical. Medical, mostly they are temporary measures. This is to buy some time before the definitive treatment is indicated. Surgery is the definitive treatment. It addresses the underlying pathology. So what are the medical managements? Elevate the head of the patient to 30 degrees. What is the rationale behind that? So elevation of the head causes increased venous drainage from the brain through the internal jugular vein, and various hypertonic fluids like mannitol and hypertonic saline are given. How does they act? These hypertonic saline and mannitol, they increase the intravascular osmolality, and they draw the fluid from the brain parenchyma into plasma or blood vessels. They cause dehydration of the brain. So when it comes to mannitol, what the dose? Dose of mannitol is 0.5 to 2 gram per kg per dose. It is not per day, it is per dose. So for 60 kg man, approximately needs 60 grams of mannitol. So each 100 ml contains 20 grams of mannitol. We need to give 3 bottles of mannitol per dose, not 100 ml. It is 3 bottles, means 300 ml should be given. So what is the route of administration? It is IV push. We have to transfuse rapidly over a period of 10 to 15 minutes. We should not give like slow IV transfusion because it will not reduce ICP. It will reduce only, it will cause diuretic if you give slowly. So you have to give IV push in the over a period of 10 to 15 minutes. And other solution is hypertonic saline. So here same, because of the increased osmolality of the plasma, it causes dehydration of the brain, it reduces the intracranial pressure. So our target is to maintain the sodium to the higher normal levels, around 140, 145. Though hyperventilation, one of the medical management to reduce that ICP transiently. How does it reduces? Hyperventilation means we can change the settings of the respiratory rate on ventilator. So we increase the respiratory rate. It causes carbon dioxide washout, leading to hypocapnia. Hypocapnia causes cerebral vasoconstriction, reduces the intracranial pressure. But this is temporary measures because if you prolonged vasoconstriction causes cerebral or brain infarct or hypoxia. So this is only temporary measures to buy some time before the definitive treatment is indicated. So definitive treatment is in the form of decompressive craniectomy, and we address the underlying pathology like we address the EDH, SDH, we address the hydrocephalus, this one. And if there is hydrocephalus, we can do EVD, external ventricular drainage. We put a catheter in the frontal horn of the lateral ventricle. We drain the CSF outside to decompose the ventricles. This is the definitive treatment. So if we don't treat the ICP rise, it will lead to herniation syndromes. What is herniation? Herniation is displacement of the brain from the normal position, leading to compression of the vital centers, the brainstem. It may lead to death also. There are 4 types of herniations normally: subfalcine, uncal, central herniation, tonsillar herniations. These are very dangerous. These are late signs of increased intracranial pressure. What is subfalcine herniation? Subfalcine means below the falx cerebri. Here the cingulate gyrus, it is pushed to opposite side below the falx cerebri. It will lead to infarction of the anterior cerebral arteries because they are closely associated with cingulate gyrus. Uncal herniation. Uncal, what is uncus? Uncus is medial part of temporal lobe is called uncus. If the uncus is pushed towards the medially, it compresses the oculomotor nerve. See, one of the causing the pupillary dilatation or pupillary asymmetry or anisocoria. A central herniation. Here the brainstem or midbrain is herniated. It descends through the entorhinal hiatus and get compressed. Tonsillar herniation. What are tonsils? Tonsils are cerebellar part which lie near the foramen magnum. The cerebellar of the tonsils herniate through the foramen magnum. They compress the brainstem and cervical cord, leading death. So herniation syndromes are very fatal and they are very late signs. We need to immediately address them. So far what we have learned, more than 20 mm of HCG of intracranial pressure is very dangerous. Then Monro-Kellie doctrine has, it says skull is rigid fixed cavity. It contains 3 components: brain, CSF, blood. In order to maintain the normal intracranial pressure, if the one component increases, it has to displace the other component to maintain normal intracranial pressure. So raised intracranial pressure is not just diagnosis, it is a race against time. We need to act early. You need to move early. So if you found this video helpful, please like, share, subscribe. You can watch my previous videos on various neurosurgical topics here. Thank you very much.